Good morning. My name is Sunaya, and I'm a recent graduate from Vanderbilt Medical School and will be an incoming pediatrics intern at Stanford. I am very grateful to have the opportunity to share a portion of our group's work today, along with Dr. Stephen Patrick, on improving outcomes for pregnant women and infants affected by the opioid crisis. I have no disclosures to report. There has been a considerable increase in the number of pregnant women with opioid use disorder in the United States, increasing from 1.5 per 1,000 delivery hospitalizations in 1999 to 8.2 per 1,000 delivery hospitalizations in 2017. This growing crisis is associated with adverse outcomes for both mothers and infants. Adverse infant outcomes include preterm birth, fetal growth restriction, stillbirth, and infant death. With regards to maternal outcomes, opioid use disorder in pregnancy is associated with not only an increased risk in overdose, but also cardiac complications, placental abruption, antepartum hemorrhage, infection, and severe maternal morbidity. The rate of severe maternal morbidity, which is often viewed as a near miss of maternal death, has continued to trend upwards, increasing 45% in the United States over the last 20 years. Severe maternal morbidity not only poses a significant risk to the health of the mother, but is also associated with adverse outcomes for the infant. Opioid agonist treatment with either methadone or buprenorphine is recommended to reduce the risk of overdose and improve pregnancy outcomes. However, at least 50% of pregnant women with opioid use disorder nationwide do not receive treatment. Buprenorphine was approved by the FDA in 2002, and since its introduction has become the dominant medication used to treat opioid use disorder in the United States, largely as a result of policies at the state and the federal level. Existing research on buprenorphine use in pregnancy has focused on comparing its clinical outcomes with those of methadone. However, there is limited research examining the impact of buprenorphine treatment versus no treatment on outcomes for mothers and infants. Given that at least 50% of pregnant women with opioid use disorder in the United States do not receive treatment, understanding the extent to which buprenorphine treatment in pregnancy versus no treatment modifies outcomes for both mothers and infants is crucial to guiding policy and public health initiatives for the future. To address this knowledge gap, we conducted a statewide population-based study to test the hypothesis that among pregnant women with opioid use disorder, buprenorphine treatment in pregnancy compared to no treatment improves both maternal and infant outcomes. We performed a retrospective cohort analysis, including maternal-infant dyad data from the TennCare database from 2010 to 2021. Birth and death certificate data were obtained from the Office of Vital Records. We included maternal-infant dyads in our study if there was evidence of either a diagnosis of opioid use disorder or evidence of maternal opioid use disorder buprenorphine prescriptions. We excluded dyads from the study if there was evidence of methadone treatment or non-buprenorphine treatment. Our primary cohort was defined as those who are continuously enrolled in TennCare from 20 weeks estimated gestational age to 6 weeks postpartum, which left us with 14,463 maternal infant dyads, of whom 7,469 received buprenorphine treatment. For the exposure, we assessed for evidence of any buprenorphine prescriptions between 20 weeks estimated gestational age and birth. Supplementary analyses measured the association of number of days supply of buprenorphine, as well as average daily dose and timing of treatment. Our primary maternal outcomes for the study included severe maternal morbidity, ICU admission, and maternal death. Our primary infant outcomes included preterm birth, NICU admission, and infant death. We assessed for all outcomes through 6 weeks postpartum. Our covariates for the study were determined a priori based upon the existing literature and clinical expertise, and listed below, grouped into the following categories: maternal demographics, pregnancy-specific characteristics, maternal infections, and substance use. For the analysis, descriptive statistics were calculated to compare characteristics of maternal-infant dieets and the percentage of adverse pregnancy outcomes in the group who received buprenorphine treatment compared to the untreated group. We also constructed propensity score weighted logistic regression models with overlap weights to achieve covariate balance, as shown in this love plot here, and examined the association between buprenorphine treatment and adverse outcomes. The propensity score analysis allows us to estimate the probability of receiving a treatment based on a set of observed characteristics, in this case, the covariates for our study, then use this score to match or weight individuals from the treatment and control groups to balance covariates and minimize variance. Our study found that among pregnant women treated with buprenorphine in the primary cohort, 94.7% identified as non-Hispanic white compared to 2.1% who identified as non-Hispanic Black. By contrast, in the untreated group, 85.5% identified as white compared to 10.2% who identified as Black. Other demographic and pregnancy-specific characteristics were similar between both treated and untreated groups in the cohort, including lack of access to early prenatal care and attainment of a high school degree or less. The presence of comorbid substance use, such as smoking, was also elevated in both groups. Between the treated and untreated groups in our cohort, the percentage of adverse pregnancy outcomes was significantly lower in dyads who were treated with buprenorphine compared to the untreated group, 25.4% versus 30.8%. Specifically, the buprenorphine treatment group had a lower percentage of severe maternal morbidity events, preterm births, and NICU admissions. There was no statistically significant difference in ICU admission, maternal death, or infant death between the groups. After adjusting for covariates through propensity score overlap weighting, we found that dyads who were treated with buprenorphine for maternal opioid use disorder, as shown in this forest plot here, had a 5.1% lower predicted probability of adverse outcomes. When stratified by individual outcomes, mothers treated with buprenorphine had a 1.2% lower predicted probability of experiencing a severe maternal morbidity event. With respect to infant outcomes, infants had a 1.7% lower predicted probability of NICU admission. Most notably, there was a 5.3% lower predicted probability of preterm birth in infants whose mothers were treated with buprenorphine compared to those who were untreated. Our supplementary analyses did not find that day supply, average daily dose, or timing modified our results. Overall, we found that buprenorphine treatment was associated with a lower likelihood of adverse pregnancy outcomes for both mothers and infants. Our study has certain limitations, including the lack of randomization, as this was an observational study. We attempted to address this limitation through use of a propensity score analysis. Second, with regards to our exposure, we used filled prescription records for evidence of buprenorphine treatment, but did not observe medication administration, which could bias our results. Additionally, aside from the covariates that we identified, there may have been other confounding variables unaccounted for. Lastly, there are limits to the generalizability of the study, as this was performed at the state rather than the national level. In conclusion, our study's findings suggest that buprenorphine treatment during pregnancy is associated with significant improvements in outcomes for mothers and infants. We found that to prevent one adverse outcome for maternal infant dyads, the number needed to treat was 20. Compared to previous studies that compared methadone and buprenorphine, we did find a notable decrease in the predicted probability of severe maternal morbidity in dyads who were treated with buprenorphine. However, our most noteworthy finding was with respect to infant outcomes, where we saw a more than 5% reduction in the predicted probability of preterm birth. While efforts have been made to increase access to buprenorphine through state and federal legislation, pregnant people with opioid use disorder continue to face significant barriers to access. Our findings thus underscore the urgent need for treatment expansion nationwide. I'd like to acknowledge all the members of our research team, in particular our statistician, Elizabeth McNear, for all of her work on the analysis, as well as my mentor, Dr. Stephen Patrick, for all of his guidance and support. Additionally, our full study titled Buprenorphine Treatment in Pregnancy and Maternal Infant Outcomes is now out on JAMA Health Forum. Here are our references, and thank you again for the opportunity to share our group's work.